Bismillahirrahmanirrahim. In the name of Allah, the most gracious, the most merciful. If you change the way you look at the things you look at change. Assalamu alaikum, everyone. I'm Dr. Mahnor Khan, postgraduate president in Department of Community Medicine. Today, I'm going to critically appraise a randomized control article under the kind supervision of my worthy professor, Dr. Saira Afzal. So here's the article title and its PDF link: Comparison of breast cancer patient satisfaction with follow-up in primary care versus specialist care, result from a randomized control trial. For the critical appraisal of a randomized control trial, I'm gonna use here the consort list. It is the consort list checklist in which there is subdivision of title and abstract, how should be the method written, how the introduction would be there, results, discussion, and other information. So we're going to start with title and abstract. Title should identify the article or study as a randomized control trial. And in abstract summary, there should be trial design, methods, results, and conclusion. So title, as the title says, comparison of breast cancer patient satisfaction with follow-up in primary care versus specialist care, result from a randomized control trial. So a criteria of title is fulfilled. Summary, background, routine follow-up of breast cancer patient in specialist clinic is standard practice in most countries. Follow-up involves regularly scheduled breast cancer checkup during the disease-free period. The aim of follow-up are to detect breast cancer recurrence and to provide psychosocial support to the patient. However, little is known about patients' view on breast cancer follow-up. Aim to assess the effect on patient satisfaction of transferring primary responsibility for follow-up of the woman with breast cancer in remission from hospital outpatient clinics to general practice. Method, randomized control trial with 18 months follow-up in which women receive routine follow-up either in hospital outpatient clinic or from their own general practitioner. 296 women with breast cancer in remission receiving regular follow-up care at 2 district general hospital in England were included in the study. Patient satisfaction was measured by means of self-administered questionnaire applied 3 times during the 18-month study period. Result shows the general practice group selected responses indicating greater satisfaction than did the hospital group on virtually every question. Furthermore, in general practice group, there was a significant increase in satisfaction over baseline. A similar significant increase in satisfaction over baseline was not found in the hospital group. Conclusion, patients with breast cancer were more satisfied with follow-up in general practice than in hospital outpatient department. When discussing follow-up with breast cancer patients, they should be provided with complete and accurate information about the goals, expectations, and limitation of the follow-up program so that they can make an informed choice. Keywords used for this article was breast cancer patient satisfaction, randomized RCT randomized control trial, follow-up, and primary care. So as we see in the summary and abstract, trial design is mentioned, a method is explained, results are mentioned, and conclusion is given. In introduction, we focus on background and objective. Scientific background and explanation of rationale should be there, and specific objective or hypothesis should be there. So it is an introduction. Routine follow-up of breast cancer patient in specialist clinic is standard practice in almost countries with specialist cancer care system. Routine follow-up involves regularly scheduled breast cancer checkups during the disease-free period. Its principal goal is to detect breast cancer recurrence and new contralateral breast primaries, and other main goal is to provide psychosocial support to the patient. As demands on specialist resource rise with the increase in the prevalence of diagnosed breast cancer and evaluation of specialist-based follow-up versus a primary care model was warranted. To this end, we conducted a randomized control trial of specialist versus primary care follow-up of breast cancer patient. Full description of study, participants, study methods, and results of the primary outcome of time to diagnose of recurrence and health-related quality of life are reported elsewhere. The results show that general practice follow-up is not associated with increase in time to diagnosis of recurrence, increase in anxiety, and a deterioration in HRQL. So, scientific background is mentioned, explanation of rationale highlighted yellow is mentioned, specific objective or hypothesis, although not clearly mentioned, but is merged with rationale. In method, we focus on trial design. Either the trial design is described, and if there is any important changes made after commencement of the trial, is they are mentioned. We focus on participant. What is the eligibility criteria of participant? Settings and location is properly mentioned or not? Intervention is mentioned or not? Outcomes with pre-specified primary and secondary outcomes measures are mentioned, and how they are assessed. Regarding sample size, they should be mentioning of how the sample size was determined or calculated, and if it is applicable, then what was the analysis and guidelines regarding that. In RCT, the important part is randomization. The randomization method is should also be mentioned there, as how the sequence was generated, how the allocation and concealment mechanism was there or not, as implementation regarding the randomization, who generated random allocation sequence, who enrolled participants, etc. Blinding care is there or not, and if they have used any statistical methods for the randomization, are they mentioned or not. So in method, 296 women with breast cancer in remission and receiving regular follow-up care at 2 district general hospitals in England were chosen. These women were taking part in RCT to evaluate a primary care-based system of routine breast cancer follow-up, whereby they were randomized to one of two groups: continued routine follow-up in outpatient clinic according to usual hospital group, or routine follow-up from their own general patient practice group. Ethical approval to conduct this study was taken. So here's the measurement and analysis of patient satisfaction. The instrument used in this study measurement and analysis of patient satisfaction. The instrument used in the study to measure patient satisfaction had to adaptable to both hospital and general practice group. No published instrument was available that satisfied all the criteria. So, as they were using the questionnaire for the hospital patient NHS, advised by NHS department of England, and there was not any questionnaire available for the general practice group. We therefore decided to use an instrument developed in UK by the College of Health. The instrument consisted of 15 statements, each with 4 response categories. Yes, I agree sometimes. No, I disagree, I can't agree, sort of. Questions have been grouped into 3 categories: question related to service delivery, question related to consultation, and question related to continuity of care. 3 point of view were assessed during the 3-month study period: baseline, mid-trial, and at the end of the trial. The reliability of questionnaire, the internal consistency of item in questionnaire was examined at each of 3 times of measurement by calculating Cronbach alpha. The patient satisfaction instrument formed part of a questionnaire package containing the instrument measuring HRQL described previously, and a trial was sent within 2 weeks. So as we see, there is complete description of trial design, important changes to methods after trial commencement as the questionnaire was modified, eligibility criteria of participant is mentioned, setting and location is mentioned, and intervention for each group is mentioned, defined pre-specified primary and secondary outcomes are likely mentioned, and if there is any changes to trial outcome after the trial commencement, it is not clearly mentioned in the methodology, and how the sample size was determined and calculated, it is also not mentioned. What I found, the randomization explanation of this study was quite poor, as there is not mentioned how what the method was used to generate the randomized allocation, type of randomized allocation, which mechanism was used, who generated the random allocation sequence. These all things were not mentioned, but the description of similarity of intervention were mentioned, statistical method used were mentioned, method for additional analysis such as subgroup analysis and adjusted analysis wasn't mentioned. Now we will move towards the result section. In result section, the article should know what was the participant flow, which recruitment was done, baseline data, number analyzed, outcomes estimation, this harms if done during the study. These all things should be mentioned according to consort checklist. So here are the result. Response rate after the denominator was adjusted for patient who had died or moved. The response rate in the general practice and hospital group respectively were 99%, 147 over 148, and 95.3%, 141 out of 148 patient at baseline, 97.2%, and 88.7% at mid-trial, and 97.2% and 88.1% at the end of trial. No significant difference between the two study groups on responses to baseline patient satisfaction questionnaire. In hospital group had fallen just above the 88%, while remaining above 97% in general practice group. Non-responders in the hospital group were compared on baseline characteristic and selected domains of HRQOL instrument. We see the patient satisfaction with service delivery, and satisfaction with consultation, and satisfaction with continuity of care. In further slides, these tables are also mentioned. In patient satisfaction, the general practice group selected responses indicating greater satisfaction than did the hospital group on virtually all questions. Furthermore, in general practice group, there was a significant increase in the proportion of patients selecting responses indicating greater satisfaction at mid-trial over baseline. Satisfaction with service delivery, almost all patients in both general practice and hospital group were seen within 20 minutes of their appointment, which is mentioned all with details in table 1, will be coming in upcoming slide, reflecting a significant increase over baseline for both groups, which is mentioned in table 2 and 3. Most patients and general practice group then in hospital group could see the doctor on same day for urgent problem and had enough time to discuss problem with their doctor. The general practice group showed significant more satisfaction over baseline, while the hospital group showed no changes. Satisfaction with consultation, both related to aspect of patient-physician communication. More than 1/4 of patients agree it was difficult to discuss concerns with the doctor, that doctor should listen more to what they said, and that the doctor should tell them more about their problems and treatment. Significantly more patient and general practice group than in the hospital group were satisfied with this aspects of consultation. and significantly more were satisfied than they were baseline. Satisfaction with continuity of care, almost 90% of patients in general practice group saw a doctor who knew them well at their follow-up visit as compared to the approximately 50% of patients in hospital group. Uh, in the hospital group, there was no change over baseline in the proportion of patients who were satisfied with continuity of care, which is mentioned in table 3. In general practice group, there was a significant increase over the baseline in the proportion. So here is the table 1. This is the table 2. Their outcomes are mentioned previously. It's the table 3. So for in result section, for each group, number of participants who were randomly assigned received intended treatment and were analyzed for primary outcome were mentioned for each group. Losses and exclusion after the randomization together with reasons were mentioned. That dates defining the periods of recruitment and follow-up, although the total period span was mentioned, but date wasn't mentioned along with. So it's not properly mentioned why the trial ended or was stopped. This study continued and the trial ended, and why stop isn't mentioned. The table showing baseline demographics and clinical characteristics for each group. If you will review the tables in detail, the demographics is not mentioned. For each group, number of participants including each analysis and whether the analysis was original assigned group, it is mentioned. Although it is not mentioned in text form, but is mentioned in tabular form. For each primary and secondary outcome result for each group and estimated effect size and precision is mentioned. Results of any other analysis performed including subgroup analysis and adjusted analysis distinguished pre-specified from exploratory or important harm or unintended effect in this in each group are not mentioned. In discussion, we focus on limitation, generalizability, and interpretation. Here's the discussion. The instrument used in the study included questionnaire pertaining to all but not one of these dimensions. The study findings generally high level of satisfaction in both groups is consistent with other researchers on the patient satisfaction. Result of patient satisfaction surveys are usually highly skewed, with most patients giving high satisfaction rating. There is always a problem in finding validated measurements of satisfaction with appropriate content when making a comparison of patient experiences across the disparate settings and services. Also, the results of trial provide one of the few pieces of advices to examine responsiveness, sensitivity to change of a patient satisfaction questionnaire, and a number of items of the instrument showed significantly sensitivity to the change. For example, 100% of cancer patients rank technically competence as important to satisfaction. 3 is there is evidence that patient criteria for satisfaction may be specific to the disease problem and medical setting. Technical skills may be of greater importance in the specialist setting, while other dimension of satisfaction may be greater importance in the general practice setting. The hierarchy of concerns may influence level of satisfaction with patients regarding continuity of care, interpersonal factors, and factors related to service delivery important only after they are confident in technical skills of the practitioner. In both studies, however, the results were similar with respect to the rush nature of follow-up visit. The complaints that there was insufficient time to obtain information at follow-up visit documented in the focus group study is supported by finding the study that half of the patient in the hospital group felt that there was not enough time for the discussion problem with their doctor. So, as we discussed in highlighted area, trial limitation, addressing source of potential imprecision and, if relevant, multiplicity of analysis. There is mentioned generalizability. In last paragraph, we can see they has generalized the steady result interpretation consistent with result benefits and harms, and considering other relevant evidences. It was also mentioned in second slide of discussion. Conclusion: an important concern regarding the results of this research is that purchasers of health service would interpret the result as indicating that specialist follow-up is unnecessary for all patients, and wholesale devolution of follow-up to primary care will occur. It is important to provide patients with information they need to make informed choices. It is also important to implement a flexible system that can respond to the needs of individual patient. Giving patient accurate information and offering them a choice is consistent with finding that patient want more information, would like to involve in the decision making process, and experiencing better psychosocial adjustment if good communication is a part of their cancer care. In other information, the author should mention the registration number. If registration number is there, also the details of and protocol should be mentioned. The funding source, if there, should also be mentioned. So in whole article, we didn't found the registration number. So second point is also couldn't be found. But the regarding funding and methodology, the author mentioned that there was no funding provided. So here are the strengths. According to you, anyone wants to add what they found the strengths of this article? Anyone? According to my review, the article title and the issue which was conveyed through this article was really important. Title, abstract, those were written properly, but the methods and randomization, which was an important part of the RCT, that was not elaborated as should be. Elaboration was needed. The registration number wasn't there, but way forward, and everything was concluded very well in this article. Limitation of this article was as they didn't specify the time period and the date from where the study is going to start and gonna end, and what were the limitation, inclusion exclusion criteria during the study, and if there is any amendment made except questionnaire, that were not mentioned in this article. Here is the YouTube link of our channel. Kindly like and subscribe. Thank you.